Radhika ma'am, please start.
So, very good evening to all and a warm welcome. So, today is the first of the series of the Foxy JOGI ICOG clinical research activity, and I'm sure I am already able to see some of the people in the audience who have been with us in the last years. A warm welcome to you, and also a warm welcome to the people who have, test waters this time. So I'm sure you're not going to be disappointed. It's going to be extremely interesting. So everybody, on the behalf of all of us, I welcome you all. Over to Dr. Parag and Dr. Sujata, who are very important office bearers. Dr. Parag is the chairperson ICOG, and Dr. Sujata is the editor-in-chief JOGI. So a warm welcome to you, and over to you, Dr. Parag, followed by Dr. Sujata, please.
Yeah, thank you, Dr. Radhika.
So before you start, Dr. Parag, I just wanted to ask Nilima to share the slides. And after this, I think Pradnya can take over also.
Yeah, but Parag, you can start first.
Let's
Radhika ma'am?
I think you can switch off the slides, not needed. Thank you. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all in the first episode of the research methodology program, which is brought to you by Foxy ICOG and JOGI. At the outset, let me thank the editor-in-chief of JOGI, Dr. Sujata Dalvi, and the entire editorial board for joining hands with us. The research methodology is something which is the passion of Dr. A.G. Radhika, and I must appreciate her efforts because she has come up with a book which was released recently during the ICOG conference. I'm looking forward to having an interesting program wherein Dr. Radhika will be talking about checklist, and then we'll have two young boys, I should say, who will be presenting two interesting articles. My best wishes for the program, and I hope all of us go back home enriched with some great information. Thank you very much.
So thank you, Dr. Parag, for a very kind introduction and starting of the program. But from my side, that is journal side, welcome one and all for this Foxy ICOG JOGI Research Methodology and Journal Club program. At an outset, I would like to express my attitude to ever enthusiastic Foxy President, Dr. Sunita Tanulwadkar, of course, ICOG Chair, Dr. Parag Biniwale, Foxy Secretary General, Dr. Suvarna Khadilkar, Vice Chair, Dr. Ashok, and Secretary, Dr. Sarita, and of course, co-convener of today's program, Dr. Radhika. Research methodology has become a part and parcel of a curriculum so far as postgraduate and undergraduate students are concerned. And it has also created lots of interest so far as even clinical practitioners are concerned. Because nowadays, whether you are in a public hospital or in a private hospital, everybody wants to know something about the research, and they would want to know something which is new so that they can implement it for a better patient treatment. So it's not always that research methodologies only restricted to a public hospital. Even the corporate hospital want the research methodology to some extent or the other so that everybody is involved. And myself and Dr. Radhika, we have had many meetings, and finally we have come to a formation of a program whereby which she is going to have mostly a practical modules about different ways in which a research methodology can be done. At the same time, we do have two journal articles which will be read by different people. This time there are two persons, one from Bangalore and the other one from Mumbai, but we'll pick up students from different zones so far as India is concerned, and it need not be always an article in our journal, but it may be articles which is peer reviewed in some different journals so that we have a different experience of the same. And I'm sure this will go a long way so that patient will, so that those who have logged in will come to know what is new. So far as clinical practice is concerned, they can implement it. So far as patient treatment is concerned, and this will help them treat the patient in a better and a confident way. So I would like to now give my thing to our MOC, Dr. Pradnya Changade, to start off with the program. Thank you.
So,
So, good evening, everyone. We are here at the Foxy ICOG JOGI Research Methodology and Journal Club. So, we have just had the prayer Vandana, and we have heard from the ICOG chair, Dr. Parag Binewala sir, and our editor-in-chief, Dr. Sujata Darvi ma'am. And kudos to their efforts that they have brought this Research Methodology and Journal Club program. So I think, should we begin, ma'am? If
yeah,
permission?
Pradnya, I'll
Yes,
just give a
Pradnya.
brief introduction. We did not introduce you. So, Dr. Pradnya is an assistant professor in the Department of Obs at LT, MMC, and GH. And she's the secretary and manager, Journal of Obs and Gynae of India. And as you can see, she has, mentioned a few things here. She is a girl with a lot of modesty. So, warm welcome to you. And she's going to be the master of ceremonies for today. So, we are also happy to welcome Dr. Sujata Dalvi. She's a senior consultant obstetrician and gynecologist at Global Saifi and Bhatia St. Elizabeth Rukmani Lying-in and Jain Group of Hospitals. And as you can see, the slide is full of her accolades. Welcome to you, madam. And this is none other than Dr. Sunita Tendulwarkar. She is there, always there in the background. And without her, none of the programs are ever a possibility. So we are greatly indebted to her to be there as a support person in the entire series that we are going to have throughout the year. And I think we all know her very well. And as usual, the slides are full of her accolades. Dr. Parag Binewala, I think a man of, everybody knows him. And I think he's the most popular, well-liked person in Foxy. He's a senior consultant of Obs and Gynae in Pune. He's a PG teacher and unit head at Kamla Nehru Hospital. And he is the chairperson of the ICOG 2025. So, and then of course you can see the huge number of accolades. So his modesty shows, he says, I edited the book. He is the main editor of that book that we both edited together on clinical research. So welcome to you. So over to you, Pradnya, and I'm going to stop sharing now.
Yes. So we'll now begin the first talk, which will be that Dr.
Sorry to interrupt again.
Sarita
I
ma'am
think
has
Dr.
joined.
Sarita here. So
Yeah,
Dr.
welcome, ma'am.
Sarita, so we are initiating. This is the first session. So we are also sitting into our places. So welcome to you. And we would like you to address also, give a brief address, and then we will start the program.
Thank you, Dr. Radhika, and I congratulate Dr. Sujata Dalvi and Dr. Radhika and the team for this initiative. I think last year we did have the program, and this year we have started it again with some modifications, and I'm sure that it's going to be a very, very successful program. So I wish you all the very best and look forward to this evening. Thank you.
Thank you so much, ma'am, for sparing your valuable time. And we'll begin with the first talk, which is by Dr. A.G. Radhika. She will be speaking on checklists. And let me introduce Dr. A.G. Radhika. She is a National Coordinator for Clinical Research, Foxy, National Corresponding Editor of JOGI. She is a LMIC representative and is working on guidelines for international network. She is a recipient of the ICOG Visiting Professor Award, Foxy Corion Award. Is a WHO Fellow in Advanced Course of Monitoring and Evaluation, Innovations in Dynamic Health Systems. She is an expert reviewer and several publications to her credit. Welcome, ma'am.
Thank you very much, Pradnya, for the kind.
Yes, ma'am.
Thank you very much. So, like I said, it's a pleasure to be here again. So today we are going to focus on the checklist for study design. And the difference this time over what we've been doing last year is that we are going to have a hands-on sort of a thing so that we are able to actually do what is getting told to us. So this is going to be such a session. So what are reporting guidelines? So it is a simple structured tool for health researchers to use while writing the manuscripts. So it is not only while writing the manuscripts, these are also checklists while we are actually formulating a project. So these are reporting guidelines and these are checklists while formulating the protocol. So these are a checklist. This could be in the form of a flow diagram, or it could be structured text to guide the authors in reporting a specific type of research developed using explicit methodology. So these checklists are basically designed to make it easy for the researchers and authors to follow, can be used when planning and as well as while publishing. And it is important for us to also know that journals now require authors to submit a completed checklist of an appropriate reporting guideline for the respective study design at the submission to confirm that each item has been addressed in the manuscript. So it saves all the trouble to the editorial team to have those each point to be ticked. And incomplete information in the research report, certainly we would all understand that it can cause a delay or a negative response from the editorial team, and it could also result in reduced citations. Our work will not be seen at all. So the impact of checklist was very well appreciated through various the publications, and this was our own Dr. Soumya Swaminathan. She published in 2019. And what she said was these checklists are extremely important. They result in a better reporting of statistics. There is an increased deposition of data in the public repositories. There is better reporting of the reagents, meaning the interventional and the diagnostic studies. The animal models have a better reporting, and there is the bias in the practices are also reduced. So there is a huge impact in the statistics which get reported using these checklists. And the degree to which these checklists were seen to be continued in implementing, irrespective of getting implemented, irrespective of journal submission, was to a large extent in 23% and to a moderate extent in about 28%. Meaning, when you use a checklist, 50% of the authors they had a basic change in their practices. So that is a huge impact. And I think we must know about these checklists today because, like I said, majority of the journals, they want that to be there. And number two, we need to also know, what is required for our, sorry about that, it got, can you see my slides? Are my slides visible?
Yes, ma'am. Yes.
Oh, it disappeared from my window. So I'll stop share and share again. Yes. Right. So this is a checklist which looks fairly busy, but then let me tell you, it is quite simple to understand. So on this side of the graph, this basically is for secondary studies, meaning the systematic reviews. So if you have quantitative data and if there is a review that you are doing, and if it is observational studies only in your review, it is MOOS. The checklist is called as MOOS. And PRISMA, I am sure majority of us are already familiar now, is the checklist which is used for systematic review of quantitative studies. And if this was a qualitative study, then it is NTEC. For animal studies, it is ARRIVE. For randomized control trial, it is CONSORT. So on and so forth. So as you can find here, there are so many different types of checklists that are available. And it is even there for case reports and case series. So CARE is for case reports and case series, right? And you have one for diagnostic and prognostic studies. You have some for biomarkers. So the world has really moved on, and we need to be aware of these checklists. So these can be obtained from, there are dedicated links which are available to download each, but all are available in one site, and that is the Equator. So those of you who have the access to the internet, I'm sure all of you have. So I think for ease of everybody's access to the net, what I can do is I can copy the link and put it in the chat box so that you are able to access the link. So these are two very easily accessible free sites which can be accessed by all, and this helps us to um, go through the various sites. So now let us see. So we just opened the Equator network. So I'm sure you're able to see this Equator network. So here, this is the list of the checklist that I had showed you in the slide. So for randomized control trial, it is consorts, consort checklist, observational studies probe. This is for individual studies. So when you have the secondary data, meaning a systematic review, it is MOOS. Systematic reviews is Prisma. Now you will also find that there are extensions. So extensions today are the various other kinds of studies which could be there. For example, so I think we will talk about the extensions a bit later. Once let us get familiarized with these, the checklists that are available. Incidentally, I would encourage everybody to have a look at this site because it gives you all the basic idea. What is the reporting guideline? Search how to look for the reporting guidelines, how to browse for the reporting guidelines by specialty. There are some which are already under development, and these help us. It's almost like a hand holding for developing a study protocol. Now, if this looks a little kind of busy for you, then what you could possibly do is you can go into the next one that I have posted there, and that is the Goodreads. So this is even easier. This is more easy to follow and very easy. So it says, what are you writing, right? So here, are you doing a case control study, case report series, cohort study, randomized control style, psychological intervention? So you could choose the kind of study that you are wanting to do. So, and it also gives along with it the checklists that are available, right? So let us take the care one, right? So then you press go, then it opens up the checklist for you. Now, there are two ways of doing this. So if you would like to know more about it, you can read more. It gives you the care guidelines developed by an international group of experts are designed to increase accuracy, transparency, and usefulness of the case reports. So it gives you an idea of what what this checklist is about, and then you could either complete it online. Okay, you have it already here. You could fill up the spaces here, or and see on the right side, it also gives the patient perspective and the informed consent. So it is so useful for us to develop this kind of a point by point system for us to develop a study design and also for publishing. In case you would like to do it separately, you just want to sit and do it on your own, so you could download it on your on your desktop, right? And what does the checklist look like? So I would encourage everybody to have a look at this site and go through these. So these are the reporting items. So it starts with the title, the keywords, the abstract. So how do you write the abstract? Introduction. So in case there is you would like to understand how to write the introduction, what is unique and why is it important? When you go through the hyperlink that is available, then it gives you how to exactly write, how to summarize each point in your abstract. So what could be even, what could be better than such kind of checklists that are available to us? So then within this abstract, how to write other than writing the introduction, how to conclude, then how to write the entire manuscript. So I think it is extremely important. I think it is extremely useful for us to understand, these checklists for our day-to-day practice. So that is all. Rest of it is for everybody to do their own hands-on thing. So this gives you a fairly good idea. You become familiar and more comfortable in using these checklists, and go on with your undertaking a research protocol as well as publishing. So thank you so much from my side.
Thank you so much, ma'am, for that elaborate talk on checklists. Now we will begin with the journal articles, and for this we have three experts. We have Dr. Madhuri Patel, madam, Dr. Geeta Balsarkar, madam, and Dr. Asmita Rathod. Can we have their CVs? So let me read Dr. Madhuri Patel, madam's CV for you. So we know that Madam has just completed her tenure as Secretary General of Foxy, and she has been the past Editor-in-Chief of JOGI, Joint Secretary for Foxy, Committee Member Figo Preetam Birth. She is an Honorary Clinical Associate at Nauroji Wadia Hospital and Consultant at Police Hospital. She is a former professor and has been the HOD OBGYN at ESIC Hospital, and she has several awards, including the Mrs. Shaileja Narayan Pandit Award, Appreciation Award, Dr. Ganatra Charitable Medical Center Award. Welcome, madam. We have amongst us Dr. Geeta Balsarkar, madam. She is Professor, Unit Chief at Nauroji Wadia Maternity Hospital. She is currently the Secretary of MOGS, past Editor-in-Chief of JOGI, and the past President of AMWI. She has also been the President of the Mumbai Menopause Society. Welcome, madam. Our third expert is Dr. Asmita Rathod. She is Director, Professor and Head OBGY at Maulana Azad Medical College, New Delhi. Her area of interest is maternal and fetal medicine. She has been the President of the AOGD in 2022-23 and has several publications and awards to her credit. I request the experts to kindly introduce the speakers and proceed with the next session.
Thank you, Dr. Pragna, for your kind words. Respected our President, Dr. Sunita Tandurwalkar, Parag as an ICOG chair, then Dr. Ashok Kumar, Sarita Bhalerao, and of course our editor-in-chief, Dr. Sujata Dalvi, and all my dear friends and my co-chairperson, Dr. Geeta and Dr. Asmita. It is my proud privilege to introduce Dr. Madhva Prasad. He is my very, very, we have worked together when I was an editor-in-chief, and we have worked together, and he is most sincere, I will say, the person in the journal I have found. Of course, there are many other people, but he was, he's a young blood, and he's doing so many journals, activities, and he's attached to many, many other journals. And I'm really happy to introduce him. He is a associate professor, Department of OBGYN, and associate medical superintendent pharmacy at St. John Medical College Hospital. And he's a national corresponding editor, Foxy Journal 21 to 26. And I must say that Madhva has done his PG from KM Hospital. And we are very, very, he was at the secretariat level also. But because he changed his proposed from Mumbai to Bangalore, and therefore he had to resign from the post. So now he's our active national corresponding editor. Dr. Madhva, over to you. Madhva, can you hear me?
Yes, ma'am. Can I take over? Thank you, ma'am, for a kind introduction. I thank Foxy and ICOG for giving me an opportunity to speak. Ma'am, may I proceed with my presentation? Yes. So, today we will be talking about two things. It's a very brief presentation. One, I will narrate my own journal, which is focusing on implementation of response to VAW. And we will also discuss and introduce and discuss a concept called implementation research. So basically, when we were planning this program, the request was to do something different, to give a different take-home message apart from the usual topics that are done. So let me run through this article. This is an article which was published in the Journal of OBGYN recently. It is implementing an educational intervention on formal training of MBBS interns regarding response to violence against women. So as you know, uh, you know, a few years back, the concept of Dura came in and it gained a lot of popularity in not just Foxy but the entire Indian community. So it was at that point in time that I was planning a project, and I thought that the DIRA should not stop just by at a superficial level, but we should go deep. And me being an academician, I thought that we should do something to uh, you know to disseminate it at a much deeper level, and that was the thought process behind this article. Next slide. So violence against women and sexual assault are major problems in the real world scenario. There exist lacunae among medical practitioners regarding response to VAW. Despite increasing awareness and improved sensitivity, teaching students how to handle VAW is a neglected part of medical education, which this project addressed. Next slide. So what we did was a one-day educational program using the, there is a standard curriculum which is given by WHO, which is called the LIVES curriculum. I'll just come to it. It has interactive lectures, small group discussions, and role plays. And it is given as a form of curriculum which can be rolled out to everybody. So what we did was we utilized the pre-validated questionnaires, and these contain 10 stems and 85 individual items, and we compared the scores to calculate the impact. Next slide. I just ask all the audience to take a moment to take a screenshot of this QR code. If you are on a laptop, just take a photo. If you're on a screen, just take a screenshot. It will take you directly to a treasure trove of material which is available in the WHO website. At the international level, they've taken so much pains to give something which is absolutely standard, which anybody can utilize. Absolutely anybody can utilize, and I just encourage everybody to utilize this. Next slide. So this is what it looks like. There is a module. There is a next slide. Yeah. So there are handouts. There are resources, and there is a slide deck. For all the sessions, it runs to 315 slides. Next slide. So what do those slides have? Orientation introduction, understanding violence against women as a public health problem, understanding survivors' experience, guiding principles of management of VAW, communication skills, when to identify and how to identify intimate partner violence. Next. Knowing your own setting, first line support, clinical care, forensic examination, further clinical care including treatment, documentation, and care for mental health and self-care. Next. So this LIVES curriculum has listen, inquire, validate, enhanced safety, and support. So that's what it stands for, LIVES. Next. So what did we do? We did teaching material finalization, which is the LIVES questionnaire. We conducted pre-test, then we implemented the curriculum, and then we did a post-test question. Next. So there were so many stems, and we spoke about all those different items. I told you there are 10 stems and 85 items. Next. So our results look like this. There was improvement in the background knowledge, warning signs, ability to communicate, ability to inquire, overall self-perception also in baseline scores regarding gender roles did not change, and it suggested a highly mature population that they already know about. So the audience must be wondering, okay, so what is the big deal? This is neither novel. VAW is an old problem. Okay, there is a new curriculum we implemented. Why are journals even accepting this kind of an article? What is the big novelty? Next slide. Right? So there's nothing new. Anybody can do it. What is so big about it? This is where we come to the topic of, which I wanted to discuss today, which is, next slide, implementation research. Next slide. So what we need to understand about implementation science is, what is it? How is it important? Because it guides policy, practice, and science goals. How is it related to different types of health research? What are the various components? And how does one plan, conduct, and report these types of implementation research? And how do you follow up on implementation research? Next slide. So basically, what happens is we are very, very familiar with the first part, that is clinical research producing new evidence and new innovation. But are we taking efforts to ensure it gets implemented? Are we ensuring that it is adopted into direct local, uh, situations and environments? Are we focusing enough on practice change and interventions which are ensuring that that particular new innovation is utilized adequately for the person needing it? That is the crux of the implementation research. Next slide. So if you look at this very cleanly, we think in our mind that there is a research done in the basic lab. It goes to clinical research and directly improve, health will improve. No, that's not how it is. For every basic lab research which is conducted, out of three, only one goes towards clinical research, and out of three clinical research results, only one goes towards improved health. Now, what is this? Why is that only that green arrow, only that one of those three is actually improving? Next slide. That is because there is this well-known or well-defined translational problem in the implementation pipeline. There is a problem where there is a kind of barrier between an innovation reaching the end user. So we need to focus on this particular aspect also. Next slide. So, broadly, we are very familiar with clinical research where trials and studies and those things, but look at implementation research. So, in the aim and objective of a clinical research, it will be like a clinical intervention or an exposure, something like that. Whereas in an implementation research, we will be looking into implementation strategies. In a clinical research, it will be typically a procedure, a new drug, a new therapy, etc. Whereas in implementation research, we will be looking at clinicians, perspectives, organizational change, practice change, etc. In primary outcomes in the clinical research, we will be looking at, quality of life, symptom improvement, those kind of outcomes. Whereas here, we will be looking at adherence to treatment, adoption of a new innovation, etc. So, there are these important differences between clinical research and implementation research, which the modern researcher, the Indian researcher in OBGYN should acknowledge and should read more about. Next slide. So if you look at my article, I hope you'll go through in detail. To look at it, in the end, I'm concluding by saying a one-day program for MBBS interns for PAW implementation is feasible. So this particular study which I have done comes under implementation research because we know that this curriculum exists, but we have to actually do the study and suggest whether this is actually feasible and whether this is actually doable in the local scenario or no, or what were those changes or what were those challenges or difficulties in the implementation of this particular study. So those are all the things that come under implementation research. Next. So if you put all these things together, we get a definition, which is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practices, and hence to improve the quality and effectiveness of health services. For example, day-to-day scenario for postpartum hemorrhage, tranexamic acid is now approved as first-line management. How many of them are actually using tranexamic acid? This can be an implementation research. Second, influenza vaccination, right? So many guidelines that have clearly clarified that influenza vaccine is supposed to be utilized for pregnant women between 28 to 34 weeks. How many of us are actually utilizing this? Like that. So now injection TT is gone, TDAP is coming. Now, when are we going to utilize it? How are we going to utilize it? There are guidelines. Now, the old science has been replaced by new science. But has it penetrated the end user? Is every obstetrician in India utilizing that single dose of TDAP, which is recommended now? That is the question that something like an implementation science will answer, and an implementation research has to be conducted. Next slide. So basically, what will this aim at? Will be to develop reliable strategies for improving healthcare-related processes and facilitate widespread adoption. And we will look at the processes, barriers, and we will commonly look at this facilitators and barriers in implementation of, the facilitators and barriers in implementation of influenza vaccination are, something like physician knowledge, availability of a clear guideline, those kind of, right? So, so there are, this is again a process. Next slide. So I'm almost coming to the end of my small discussion. So you will get confused. Isn't this a quality improvement thing? Like, aren't we, isn't the, what is the difference between an implementation research and an audit? Basically the audit comes under a quality improvement research, whereas, the one must acknowledge the fundamental difference. When we are looking at quality improvement initiative or audits, we are looking at a something which is not very generalizable. That is, if you are conducting an audit in, KM hospital, OBG department, those results will be applicable only to KM hospital OBG department, and the results of that particular quality improvement audit will be for improving the practice within that particular location. So in science, we speak about external validity. The study you do here should be valid everywhere. So an audit you do in place X is not valid in place Y. That is the difference between an implementation research and a quality implementation research. Sorry, quality improvement initiative like an audit. That is, in implementation research, you do the study in such a manner that you will be able to project these results in an external location also. There will be good external validity. Suppose I do a study in Bangalore. It should be, those facilitators and barriers should provide a guidance to people who are doing research, say, for example, in Calcutta. It's like that, so that's the difference between a quality improvement audit kind of initiative versus an implementation research. So next slide. So I'll just come to the take-home message. We usually think that clinical trials are enough, healthcare, and guidelines are enough. Whereas, if you look at all those brown spots, the healthcare behavior and implementation research will help in taking forward the available innovations and the available medications, available instruments and available drugs. And we have to formulate strategies only when we will be able to improve healthcare through better processes and eventually give better outcomes. So, so to conclude, we need to open our eyes into implementation research also. Last slide. One more slide. Yes. So I have shared a screenshot of the head of Indian Council of Medical Research speaking on the he's urging all Indian researchers to take up implementation research, which is now being given a lot of importance by the Indian Council of Medical Research. And so I conclude my speech thus, and by thanking the members of OFC and ICOG for
thank you, Madhava. That was really very excellent. Incidentally, Madhava happens to be my registrar from Wadia Hospital. And thank you. That was really very nice. Yeah, thank you. Can we move on to the next CV, please?
Can I say a comment,
Yes.
Geeta?
Yeah.
Madhva, it was a very good presentation, and you thought of out of the box this research paper that violence against women, which is very, very high. And you are talking to our interns. They are absolutely, come out as an MBBS doctor, and you have taken their questionnaire, and then we have found it is an improvement in the study. So this is really a good study you have done, very systematically you have done. And your conclusion, I really has given a very good insight that efficacy studies, it is a clinical, health behavior, health services, leading into the effectiveness studies, leading into guidelines, evidence, based, everything and implementation of the research and ultimately improve health process in the outcomes. So this improvement in the outcome, how we can get it, you have shown in your conclusion slide very well. So well done, Madhva, and keep it up. Thank you.
Thank you, ma'am. Thank you, ma'am.
Nilima, can you display the CV of the next speaker, Dr. Sunil Tambekar? I request the experts to introduce Dr. Sunil.
Dr. Asmita can introduce. Dr. Asmita.
Dr. Asmita, can you please introduce Dr. Sunil Tambekar?
Is she
Okay,
there?
fine. I'm
Otherwise,
not
yeah,
sure.
yeah.
Geeta madam, can you introduce
Yeah,
Dr.
Geeta.
Sunil?
Yeah, he is a consultant at the Wadia hospitals, Wokard Hospital, Messina, and Apollo Spectrum Hospital. He has a lot of papers and prizes to his credit, and he is actually working in my unit. He's also a peer reviewer to many other journals, in addition to being a joint assistant secretary to the Journal of Obstetrics and Gynecology of India. Dr. Sunil, can we have your paper, please? Dr. Sunil?
Dr. Sunil?
You are
So
muted.
you have to
Sunil.
unmute Sunil. Yeah.
Now,
Was not allowed.
yeah,
Now-
Sunil, share the screen.
Hi, madam. I would like to share my screen. Thank you, ICOG. Thank you, all of the seniors and the JOGI team and Geeta madam for these kind words. I would like to go ahead with my presentation. Okay. Thank you, everyone. So when we discuss about presenting at journal clubs, we come across various type of articles and studies.
We can see your slides, Sunil.
So
He has to
especially,
make it slide share.
yeah, madam.
Okay.
So this time we decided that let us consider systematic review and meta-analysis as a topic of our journal club, so that it would benefit especially postgraduate doctors as well as practitioners, so that we understand the efforts being taken by researchers as well as doctors, and mainly these quality of studies and the research activities are done abroad. The efforts put to generate the evidence and disseminate the evidence through clinical guidelines by various bodies, so that we implement that in our practice. So we decided to discuss about Cochrane review. So we chose this systematic review and meta-analysis, which was generated in 2018 on antihypertensive drug therapy for mild to moderate hypertension during pregnancy. So systematic review and meta-analysis. Cochrane is an independent body which conducts research activities to have systematic reviews and meta-analysis, highest quality of research activity through the protocol systems. And we heard Dr. Radhika madam also regarding the checklist systems, especially for systematic meta review analysis, Prisma and etc. Anybody of us can decide and sit to go ahead with systematic reviews and meta-analysis, but this is not the way it should go. So the highest dedicated body in this field is Cochrane review team and Cochrane libraries. It's a database of systematic reviews. What they do is they repeatedly update their own systematic reviews and meta-analysis. For example, in this study, before 2018, they had conducted thrice a review on the same topic. So before this, it was in 2013, and in 2018, they further went ahead adding the study. So I'll quickly go through the article and abstract. And as I discussed, so I would like to inform our consultants and juniors regarding the methodology and how it takes for them to put efforts to generate evidence, as well as quickly going through the whole agenda of the their topic. So Dr. Edgar Abelos, Lelia Dule, Wilhelm Stanley, and Selena Gialdini. So these were main researchers. So they come from various backgrounds: clinical studies, clinical topic like obstetrics, as well as epidemiology, etc. Quickly going through the abstract. So antihypertensive drugs are often used to believe that they reduce blood pressure. But in this updated review, after 2001, 2007, and 2014, they conducted further going ahead with the comparison with the primary and secondary outcomes. What are the research methods? So that we'll see in the detail. Quickly, they are telling us regarding the selection criteria. So all the randomized control trials evaluating antihypertensive treatment, which they gave definition that again we'll see in this in detail. So data collection and analysis, 2 review authors independently assessed, and further they had removal of biases if required, third assessor also. What was the ultimate inclusion of the studies and the sample size? So they included 63 trials, data from 58 trials. The great number of 5,909 women was generated with moderate to high risk bias overall. So this is the beauty of systematic reviews and meta-analysis. So especially, students here try to understand that you are not going through the groundwork to decide and to do actual clinical study, but you are taking data and going to have amalgamation of quantitative principles, qualitative principles, and generate meta-analysis, disseminating the results. So this is the abstract as it is. I have taken right now. I won't read it. So just try to understand primary outcomes were developing to severe hypertension, proteinuria, and neonatal were neonatal death and preterm births. Secondary were eclampsia, maternal death, severe preeclampsia, IUGR, and others that we will see in the results. So same thing, primary outcome and secondary outcomes. And conclusions. So I'll come to this. So now, beauty of Cochrane studies and their whole principles and thought processes behind it, that their results and studies are available on internet for everyone. If at all simple layman people want to access the results and access the therapy which has been chosen for them, can they read it? Can Cochrane help them? So yes, so they give whatever work they are doing in a simple language called as plain language summary. I'll quickly read through this so that you understand how they are helping general people also. So what are they dealing with here? So what is the issue? So aim of this review was to determine the benefits of adverse effects of blood pressure lowering drugs, that is antihypertensive drugs, in a pregnant woman which is mild to moderate hypertension, and aim to assess the benefits and adverse effects. Why it is important? Because up to 1 in 10 women have blood pressure above normal. For some reason, their blood pressure is slightly high, that is mild to moderate, or apparently no complications. So some of these women go to develop to very high blood pressure, that is severe hypertension. And it can go to seriously affect the growth of the baby. What did we find? So my point is, so they are again going to give this plain language summary continues here. And so they are going to tell this, that how did they perform the study and what does it actually mean? And ultimately they have said it helps. There is a moderate evidence for 2 primary outcomes, but further it requires it requires further research. And now going through the actual article, what they discuss. So quickly I'll go through this so that consultants and postgraduate will be helpful for them. So general consensus for definition of like hypertension and classification, it has been given since 2000 by NHBPEP. The definition is 140 by 90, 4 hours apart. Later, ACOG Task Force Canadian Working Group improvised this and gave severe hypertension as 160, 110. And they it is again defined how it is taken, the blood pressure and cortisol sounds. So what is the going ahead with the aim? So we have discussed this. So which intervention they are going to take and which drugs work? So alpha agonist, beta blockers, calcium channel blockers, peripheral vasodilators like hydralazine, calcium channel blockers like nifedipine, and other little rare kind of drugs, serotonin receptor antagonist, cataplexin, glyceryl trinitrate, nitric oxide donors, and phosphodiesterase inhibitors like sildenafil. So whichever studies are available all over the world, they have going to include in the systematic review. So their objectives were to comparison for two things. One is with no drug or placebo, and with compared with the any other drug available, because these kind of studies they are going to get. So which studies they have included? So all clusters individually randomized trials evaluating any antihypertensive drug treatment for mild to moderate hypertension. Quasi-randomized, experimental were included, crossover were not eligible. Which were the types of participants? So women included regardless of they had proteinuria or not, that is during pregnancy and with mild to moderate hypertension. Previous hypertensive treatment, whether she was on or not, whether it was singleton or multiple. Okay, so women who had given birth before trial were excluded, and severe hypertension. Just a second, I want to shift my this batch here. 1 second. Yeah. So studies that included a substantial proportion of women who did not have mild to moderate hypertension were included unless data were available regarding the outcomes with mild to moderate hypertension. Okay, so comparison of 1 or 2 drugs or placebo. Studies were excluded when it was to treat simply less than 7 days. Comparison of 2 drugs of same class were also excluded. Drugs that aim to reduce the risk of pregnancy-induced hypertension progressing to preeclampsia are not, but they are not antihypertensive. They were also excluded. So there were primary and secondary outcomes. I'll come to the outcomes. So see now, this is important. So 1 second. So based on standard template used by Cochrane Pregnancy and Childbirth, these studies were, the research was conducted, electronic searches. So for this purpose, they searched Cochrane Pregnancy and Childbirth Trial Register, contacting important person called as information specialist. And this was concluded in 2017 for this particular study. So register is a database which contains more than 24,000 reports of controlled trials in the field of pregnancy and childbirth. Full search methods used to populate pregnancy and childbirth trials register includes search engines which are Cochrane Registry, mainly PubMed Central, Medline, Embase, CIN, that is nursing related database, and many others. And list of hand search journals also, conference proceedings also. This is also an interesting point I will discuss. So basically, information specialist identified from all these databases. Interestingly, you can see here weekly current awareness alerts for 44 journal plus monthly Biomed Central email alerts. So they have taken efforts to include each and every even small but good quality studies being conducted all over world. So it was screened by 2 people. The full text of relevant articles were done. Based on the intervention, each trial assigned a number of correspondent which specific pregnancy to childbirth review topics and added to the register. The information specialist searches the register with the keywords and results in a more specific search set has been fully accounted for the relevant review section, which they have put it into included studies, excluded studies, and ongoing studies. In addition, they have also searched the registered trials, which is on clinicaltrials.gov. So American government has this registration of and WHO International Clinical Trial Registration. Also, these two registers. Searching for other resources. The language barrier was not applied, and further cross references were also checked. So what happened further was two review authors independently assessed it. Okay, if at all they had any arguments or any disagreements, it was resolved through the discussion, or if required, even third review author was involved. Data extraction and management. So this is also a meticulous process which technology support has to be there. So review manager software. So this helps us checking the accuracy and implementation. Okay, further assessment of risk of biases. So two review authors independently assess the risk of biases. How they did it? So Cochrane has got their own Cochrane Handbook of Systematic Reviews of Intervention. That was in 2011. And if there was any problem, then again third assessor was involved. Okay, and then what is the grading system for evidence generation? So there is something called grade handbook. So this was again updated in 2013. So grade handbook. So Cochrane uses this grade handbook for generation and clarity of the results. Quickly going through this flow diagram, you can understand now. So when they started this systematic review, last study review was in 2014. So there were 49 trials. Now this time they have recorded 484 records through the database searching. Out of that, duplicates were removed. 380 are there now. Out of that, 334 reports were screened and found that they were out of scope. So now there are only 46 reports. In that also, further 20 new studies they excluded. Through the why it was excluded because of the not suitable characteristics. So that list they have given. Then they saw that there are 8 ongoing studies. Then again 9 new studies with 14 reports were included. So 9 new studies, 5 previously included studies for qualitative synthesis. So ultimately 63 were put ahead for the qualitative synthesis and 58 for the quantitative synthesis, that is meta-analysis. Okay, so usually such kind of funnel diagram or funnel is generated when there are multiple trials and multiple pointers are available in the study. So this is standard of error versus relative risk. And as you can see, these markers are for various type of antihypertensive drugs used here for the various studies. Okay, so let us move ahead with the summary of findings. To summarize it, they have given in a good concise table the primary outcomes and secondary outcomes. So now I'm not going to read again these things because these are very specific. The setting is specific, intervention is specific, comparison is specific. Okay, but let us see what evidence is generated. So primary outcomes, whether she is developing further to severe hypertension. Okay, so relative risk comes to be 0.49, and it is a moderate evidence, which is a good thing. But understand that it is from 2,558 number of participants and 20 RCTs. Proteinuria and development to preeclampsia, 0.092 is the relative risk. The evidence is low, 23 RCTs. Fetal and neonatal outcomes. So neonatal death or miscarriage, small for gestational age as well as preterm. So everywhere you can see the grade handbook is generating as a moderate evidence. Moving ahead with the secondary outcomes, maternal death, maternal mortality, 1:1 is a relative risk. Okay, so it seems dangerous. It seems difficult. So if any, noise doctor is reading or, postgraduate are searching for any drug related things, you shouldn't be fearful about such kind of outcome because you can see here grade handbook is generating evidence as a very low evidence. So because of the poor quality of research for that outcome. And as you can see here, those were 5 RCTs, but 525 participants. Okay, moving ahead. So development to severe preeclampsia were very low evidence. To eclampsia is very low evidence. A patient changed or stopped drug due to maternal side effects. It is 1:1.93. So this is also relative risk is very high, but evidence is low, not very low, low. That is plus, okay, out of 4. Elective delivery, that is induction of labor or elective C-section. So evidence is moderate. So yes, because we induce such patients and it is giving good outcome. Fetal, so transfer to NICUs as well as problems like cerebral palsy, low evidence and very low evidence. Okay, so interestingly now I'll shift our focus about the methodology and how India is contributing to it. So we should understand that if we are conducting any study and publishing our papers, it has to be of utmost quality. And my message to all postgraduates is take your thesis very seriously so that in future your study is considered as a quality study and it is included into systematic review and meta-analysis so that it helps in disseminating the evidence and help our fellow colleagues. So there were a good number of Indian studies are included. So almost 7 studies I found. So it starts from 1992, Indian Heart Journal. Then we have our JOGI Journal 2002, Dr. Banerjee. 2011, this is just a Congress study. This is also interesting. I'll come back. This is Archive of Gynecology, Archive, then Pharmacology Journal. Then this is one more pharmac-related journal. Then 2013, we have IJRCOG journal twice here. And then there was a clinical pharmacology journal, latest for 2015. So I'll show you one interesting point here. If you see this study, Dr. Pandey, this is not an article. This is not an article. This is from proceedings from our AICOG, our very own AICOG, 2011, when it was conducted in Hyderabad. Okay, so when I searched for this author, I did not find this study as a published article later. So what it is pointing towards is probably this would have been a thesis or a simple study by postgraduate doctor, which they presented into AICOG, but later she never presented, or I mean, never published it. So this is also a message to all the fellow colleagues, juniors, as well as postgraduates that please take efforts to publish your thesis and your good quality studies. Okay, so coming back to the article now, what authors are concluding as? So they are concluding that it is reducing the risk of severe hypertension, the need of additional hypertensive drugs, fetal and neonatal deaths, the evidence remains unclear. Okay. Then as far as side effects are concerned, evidence is scarce. So the previous experience of the clinician and women's preference may guide the choice of agent. So interestingly, Cochrane also is putting words, in a tricky way that clinician also put their experience into account. So that is also a point to be noted. So further, they are saying implications for research. So further high quality, large sized randomized control trials are still required for true benefits and adverse effects. We need to know the effects of both mother and baby, cost to health services, other outcomes relevant to women could be included, and the development of core outcome set, COS, for studies reporting on hypertensive disorders and prevention is currently still underway. So that is the reason after that we have not found any update on this systematic review and meta-analysis. So now try to understand that we are discussing in a journal club. We have taken this as an article, but the efforts and the work is so meticulous that it is not an article. See, if you want to go through everything, it is a 255 pages book released by Cochrane just to see whether these antihypertensive drugs are helping mild to moderate hypertension patients in pregnancy. Getting it? So when we are prescribing any drugs and having any protocols, treatment, there is so much effort behind this. So dear doctors, colleagues, seniors, and my dear postgraduates, try to understand that, have hypothesis in your mind, have research question in your mind. Simple individual randomized control trials or non-randomized control trials come under experimental study, which is a moderate level of evidence. But further, this is going to get included into systematic reviews handful of good studies, extraction of data, analysis, quality, combinations, and thorough discussions and systematic review is generated and disseminating the good quality of evidence for us doctors to practice in the society. Thank you very much, madam. Thank you very much for the opportunity. I would like to have discussion and please go ahead with the discussion. Thank you very much.
Thank you, Sunil. That was very, very informative and in great detail about each and every aspect of the presentation. So if there are any questions in the chat box, I would be happy to take. I'm just seeing the chat box.
For the sake of discussion, since I think there are no questions there.
Ma'am, I have a question.
Yes, tell me.
Madhva Prasad here. Ma'am, this is for Radhika ma'am. So this is more like an exploratory discussion. So now, science developed out of curiosity. And now we have made it so structured and so much in, like a checkbox manner that, are people losing curiosity or are people getting overwhelmed by the number of boxes that they have to tick based on all those equator, care, prisma? Some thoughts on this?
Are we talking about the checklist or what Sunil
about the
has...
checklists?
Okay, so it's checklists are basically straight-jacketed, pro formas. For you, they are actually holding your hand, guiding you through the roads. So that ensures that all deficiencies in your project planning or your publication have been, plugged. So that ensures that your complete presentation is well defined and complete in all ways, so that it is better received by the publisher. So it is for us to basically, you could plan your thing, and then when you look at these checklists, they give you an idea as to what possibilities also exist beyond what you have actually thought of. And if it is not feasible, it is completely for us to take it or leave it. That is the way it is. But these are standard.
Madhava, these are guidelines.
These have been taken through many validation, many iterative processes. So generally, they are complete. So incidentally, I find Dr. Asmita is also there. Dr. Asmita, would you like to also share your views on this matter, please?
Dr. Asmita?
Yeah, Asmita, you need to unmute yourself. Okay, so by the time Asmita is unmuting.
Radhika, can I say something about the checklist?
Please go ahead. Certainly.
Checklist will keep you within the boundaries. So you don't overshoot or whatever it is, plus you remain within the guidelines, so that whatever guidelines, whichever journal, it's always better to have a checklist. Otherwise, there's no control over whatever people are sending it. So you need that checklist definitely, whether it may be small, big, whatever it has to be, but you have to be within the boundaries itself, So that is.
But we can be lenient on certain aspects. Some journals, the certain things are important to them and they can be lenient on others, and by far they are guidelines. So it is up to the authors to see that they fulfill as much as can be possible as required by the journal.
Correct. In fact, it is and there is fine, but not too much, Otherwise, sometimes they go too much out of the box.
The authors are encouraged to, put a statement there. This study follows the consort 2024 guidelines for randomized controlled trials to ensure transparency and comprehensive reporting. If you were to say that way and add a reference to that, it certainly adds value to your document. But on the sidelines, what Sunil has been telling us around. So there are a few things, I wish to clarify regarding the systematic reviews. So systematic review is like, you want to get as much of the literature that is available out there for your, collation of the data. So it's like, casting a huge net into the ocean and get the smallest fish. So therefore, it is for us to actually, and therefore literature search in a systematic review carries a huge meaning. And every journal, whenever you publish a systematic review, you are expected to present your search strategy. The basic starting from the keywords. So when you plan a systematic review, it takes up to 2 months for you to actually develop the keywords and a systematic review strategy, which could be different for different databases. This also includes the gray literature. So the gray literature is, something which is not already published. So, this could be unpublished literature in libraries, the thesis, or it could be as mundane as something which was published in the conferences and have not been published. They have a huge meaning because the funnel plot that you showed, Sunil, that shows the publication bias. We all know the negative results are very difficult to publish. Poor English is not do not find publication. So there are various reasons why publications, even for good studies, do not take place. So the funnel plot ensures that is a one look statement. From the graph, you know whether the balance of studies exist, whether good search has been done to obtain the negative as well as the positive results. A word about the grade approach. Grade is the grading of recommendation, assessment, development, and evaluation. So, Grade Pro is a software which is available and you need to log in. It is for the Cochrane authors. A complete version is available. So, from here, you identify from the PICO statement whatever evidence was there, what is the weightage, and how good is that recommendation in terms of the strength of evidence. So, that is what those circles when plus and minus is an indication. It gives you again a visual statement of how good those recommendations are. So from all this, you develop the guideline. So the guidelines develop from systematic reviews. So a good systematic review helps us to develop a good guideline. But then there are other ways of developing guidelines. You might adapt it from an existing one, or you could even do what is feasible in your country. So, last word about Sunil saying that Cochrane words it very cleverly that the experience of the clinician is a must. Incidentally, Sunil, evidence-based healthcare is an amalgamation of what is evident, what are the robust evidence, the patient's preference, and the clinician's experience and preference. So, where the three circles meet is what is evidence-based healthcare. So, it is not binding. When you develop a guideline, it is not binding, it is not straitjacketed. It doesn't mean legally that if you have not followed that guideline, you are wrong. It is not that way at all. These are recommendations which have been developed with good, robust evidence to handhold the clinician to take a decision. So it may not be clinician, it could be even a pathologist. They have their own guidelines. So that is the way it is. So that's all from me. Thank you so much.
Thank you, ma'am. Ma'am, this was a
Yeah.
good message you have given to everyone. That is important.
Thank you.
And ma'am, as far as checklists are concerned, I would like to say one point. As simple as case reports are also bound with care checklist 2013. In our journals also, we are trying our best to see whether the authors are bound within boundaries of the care checklist. So this is also a message to all the participants that before giving anything for publication, please go through the checklist for that particular type of article.
Exactly.
So
So
yeah,
we had an excellent session now. Madhuri Patel, ma'am, would you like to comment?
and I would like to say that both the speakers were excellent. Dr. Radhika's, inputs were very, very good. And this has been very well crafted, program. And, journal, very selected people are interested in, but those who are interested, are really interested. And as Dr. Radhika said, okay, we are the, people who are interested, they get so many articles, and then from systematic reviews, so then we get the guidelines, and we have to stress upon the guidelines. Different country have a different, types of guidelines, and therefore those countries we have to follow things. We also have in our government of India guidelines, but unfortunately we don't have from our, our organization the guidelines, because our guidelines, they do not, that's why we call it as a good clinical practice recommendation, because whatever we write guidelines in FOXY, it is not, it does not have value in the court of law. And that's why we have come out with a good clinical practice recommendation, where other countries have guidelines and they have to follow that. Because I remember when we go to the other country, they literally follow in the label, everywhere the guidelines. And they divert little bit here and there, then there is a problem. But in our country, that is not the case. we are there. And as Dr. Radhika mentioned, that guidelines, where it fits, we should go ahead. Otherwise, we can treat our patient according to our expertise. But nowadays, it is an evidence-based medicine. So we request all of you to remain in that, purview that, we have to follow the evidence-based practices. So excellent, Dr. Radhika, Pragna, Sujata, Parag, and, Sarita and Ashok Kumar for the excellent team, and too Sunil and Madhva has done very good job. And Radhika, of course, your lecture was super. And your program is very, very good. So thank you once again for giving me this opportunity.
Thank you. Thank
So
you
I would
so
like to thank the experts, Dr. Madhuri Patel, Dr. Geeta Balsarkar, Dr. Asmita, for giving the expert inputs in both these presentations presented by Dr. Madhva and Dr. Sunil. Of course, the lecture by Dr. A.G. Radhika was the icing on the cake, which covered all the guidelines. So I'm thankful to our Foxy President, Dr. Sunita Tandulwadkar Madam, Secretary, Dr. Dr. Suvarna Khadilkar Ma'am, ICOG Chair Dr. Parag Binniwala Sir, Vice Chair Dr. Ashok Kumar Sir, Secretary Dr. Sarita Bhalerao Ma'am, and of course our Editor-in-Chief, who is a pillar of support for our journal, Dr. Sujata Darvi Ma'am, and the convener Dr. A.G. Radhika Ma'am for the excellent conduct of this program. And I'm sure the audience will want more, and we'll plan another program very soon. So thank you all the audience, all the speakers, chairpersons. And we'll soon be posting about our next program.
Yeah,
Thank you.
we would like to thank our MOC, Dr. Pratik Chengere.
Thank
you.
for
Pragna
working out
conducted a
all the
great job.
logistics and making so much of efforts to
Yes,
put this
yes,
in.
yes.
Thank you.
Pragna,
Thank you,
we
Pragna.
really thank you because you are also putting, so many things together along with Radhika. So excellent thing. Sujata is always there. And of course, I forgot to mention about Suvarna. So I must thank Suvarna also for this excellent program.
Thank you. Thank you so much.
Thank
Bye.
you.
Have
Thank
a good
you.
day. Yes, good day.
Bye. Bye.
Bye.
I will stop the recording.